All right, good evening, everybody. Welcome to this another session of 51st Comprehensive Course on Echocardiography. We have come a long way. We started with basics of MO2D Dopplers, then went on to do a valvular lesions and finished up CAD, cardiopathy, and diastology. Okay. Today is the 16th session of this 51st course, and we are going to show a live demonstration of various modalities, and it's going to be a marathon session today. And in case you want a break in between, just let me know. I'll go accordingly. Well, we are from Drop Institute of Echocardiography, Ultrasound and Vascular Doppler, Delhi. We are into this teaching session since April 2000. This is our auditorium where you're going to take your practical training when you come down to Delhi in the month of October and November. And this is one photograph from our fellowship hands-on sessions of the previous batches. Number of people, legends behind this training program is Colonel Prashan, Dr. H.K. Chopra, Dr. Samir Srivastav, apart from our own Dr. Naveen Sinanda, who is the international president, and along with Dr. Hansa Gupta from Gurgaon. You have been talking number of times to Mrs. Reena Dua, and we have a very young dynamic person in our center with the name of Dr. R.K. Narayan, looking after various bureaucratic and technocratic problems. We have many accreditations, right from Indian Academy of Echocardiography, International Society of Cardiovascular Ultrasound, Alabama in USA. We too take up permissions from a CDMO Northwest District, Government of Delhi. We have been getting an accredited certificates from Delhi Medical Council for a long time. Recently, they have closed it down, but I'm sure like on 17th August, we are going to have this accreditation from DMC. We are running 1-year fellowship program with Parul University, and last year we were instrumental in training echo technicians for UK, and along with this BAPIO training academies. We can boast of saying that we are the only longest running training program in India since 2000 April, especially for hands-on trainings. More than 25 years of glorious celebration, and we are going to celebrate it on 17th August 2025 in Ashoka Hotel in New Delhi. It's a unique symposium which we're going to have during this time. Many logos which developed over a period of time. And this is April 25 when we had the first 51st echo training program in comparison to the first in April 2000. This course started on 9th April 25, and the hands-on session is likely to happen after Chhath Puja and Diwali on 30th October to 2nd November. And we are going to talk about live demo in this 16th session of this 51st course of echocardiography. And I'm Dr. Rakesh Gupta, who's going to take up this topic of live demonstration from an echo path. I have collected many cases in last 7 days. They are all in my laptop with the echo path where I can demonstrate you each and everything. And today in the morning, I have recorded raw case, one of them raw case for demonstration purposes. And with this, let me switch over my presentation to a different slides formations. Give me a second so that I can stop this presentation and switch over to another presentation. I hope all of you can see my slides. Can you see my presentation?
Yes, sir.
Okay, perfect.
Yes.
So I'm going to show you the normal patient in this presentation. So there I'm going to click normal. And here's the comes normal for a live demonstrations. So how do we go about in these evaluations of coronary artery disease, cardiomyopathy, and diastology? Look, this is the first plaques view we always have. In this plaques view, you can see very well This is my RV. This is my aorta. This is right coronary cusp, non-coronary cusp, LA, LV, interventricular septum, AML, PML, LV, posterior wall. Here's a descending aorta. Now, if I want to measure my dimensions, which are important in this subject, is I'm going to stop it, move by frame to frame to get maximum size of my LA. Maximum size of LA is when the LA mitral valve is about to open up, and look, it's a end of a T wave. And I'm going to measure in my AP dimensions. So I'm going to do that in generic. Generic, I'll go to the distance. And my caliper measures my AP dimensions straightforwards. 34 millimeter, 39 is an absolute value. 34 divided by body surface area. This patient body surface area is 1.5. 34 divided by 1.5. Anybody would like to calculate that with your computer? I can tell you it's 2.3. 15 duni 30, 2.2 rather. So that is virtually high normal. Similarly, I'll save this image for all of us. And this is one value. Just you can keep on writing this value. That'll be very helpful. Next, move on to my LV dimensions. I'll freeze it again. Stop. And I'll go to end diastolic. Look, I'm at end diastolic, the maximum dimensions of LV. And I'm going to measure it again. And I'm going to use my caliper. And the measurement is basal anterior septum to basal posterior wall. Here. No, it's wrong. I'm sorry. From here to here. So it's about 47 divided by 15 is almost 30 millimeters. When the absolute value is 47, 30 is index value should be less than 3.2 meters centimeter per meter square body surface area. So both my LA, both my LV, they are normal as far as index value is concerned. Now some amount of MR or TR, and here I can see my anterior interventricular septum as well as the posterior wall or inferior wall. Anybody can tell me what is this wall is? Is it inferior or posterior?
Posterior wall, sir.
Anybody else?
Posterior wall.
Posterior, sir.
Why do you say it's a posterior wall? Why not inferior wall?
So we'll get the inferior wall in the 3-chamber view.
The papillary muscles are not attached.
Look, if I freeze this image, look, this image categorically tells you that this is not in posterior wall, this is inferior wall.
It is inferior wall. Yes, sir. It has papillary muscle.
So if it has a papillary muscle, it is definitely a inferior wall, not the posterior wall. All right. Same. We are seeing a papillary muscle over here. Let's go to short axis view at the level of papillary muscles. This is septum. Opposite to septum is lateral wall. This is anterior septum. Opposite to anterior septum is posterior wall. And this is what? Papillary muscle present on the lateral annulus, and this is the papillary muscle present on the medial annulus. And in short axis, the contraction looks to be reasonably good. And this is what we say is looking after the presence of hypertrophy, eccentric hypertrophy, concentric remodeling, and normal LV geometry. So what we did, I'm going to measure you for that again. Let me go that. This is my interventricular septum. This is my posterior wall. This is interventricular septum during systole. This is posterior wall during systole. So look what exactly I'm getting. It's not seen over here. Yeah, it's there. RWT is 21. This software does not have that mass, but this is how we measure it for LV hypertrophy. We are not measuring this for LV dimensions. We are measuring for LV hypertrophy. So what was the values? Let me go back and show you the values again from the recorded one, because my machine, the updated one, has got this value. It says RWT less than 4.2, LV mass more than 115 in a person who is a female. Kavya Nathani is more than 95. So she belongs to eccentric hypertrophy. Cutoff for females is less than 0.42, less than 95 grams per meter body surface area. So this is less than 0.42 and this is more than 95, suggestive of this patient has got an eccentric hypertrophy. If this would have been 0.43, this would have become concentric LVH. If this would have been 0.43 and this is less than 95, this is known as concentric remodeling. So this lady who has come for echo has got eccentric LV hypertrophy. Now let's move on to the next picture, pulmonic flow patterns. And this is the most important thing which you like to see in CAD. Look carefully, this lady has got an intra-atrial septal aneurysm. This is moving on either side. It should measure it for more than 1.55 centimeter on either side displacement. What is the structure seen in this? Thrombus? Anybody? It's moving around. What is this?
Eustace.
Correct. It's not Eustachian valve. It's a Chiari network.
Yeah.
The Chiari network is a long elongated undulating membrane present in RA. Normal phenomenon. Nothing wrong about it. This membrane is during the fatal period, which directs blood from IVC to fossa ovalis to LA. Okay. Now, segments of LV, we have to see in all three different views. This is my septum. This is my lateral wall. Look, lateral wall has got papillary muscles. So wherever the papillary muscle is attached, this is mid segment. This is apical. This is basal. Opposite papillary muscle, this is mid septum, apical septum, basal septum. Then we go to two-chamber view of a same patient. Now we can see a papillary muscles over here attaching in between. This is anterior wall. This is inferior wall. And finally, we go to three-chamber view. And this is now, there's no papillary muscle seen over here. So this is classical anterior septum and this is classical posterior septum. Posterior. So whenever we talk of a wall motion abnormalities, we are not going to talk as many of your teacher, many of your seniors and many of your professors, they just look at this four-chamber view and tells you, look, it's normal, man. It is not true because we are not looking at the complete segmental wall motion abnormalities. If we have to look for segmental wall motion, we have to go to four-chamber view, two-chamber view, three-chamber view to arrive to a segmental wall motion. Correct? Now the next question is, most important thing for normal LV function is, we have to evaluate ejection fraction. So let me show you how do we evaluate ejection fractions. So I'm freezing it to end diastole. I'm going all the way to end diastole. Maximum size. This is the maximum size of LV. Once I see a maximum size of LV, what I'm going to do next? I'm going to go to measure. And measure by what? By modified Simpson ejection fraction. Look, how do I start? I start with the medial annulus. Trace it across black and white borders. Go to the apex, again lateral borders. And bring it to, say, attached to the apex. Now see, what is end diastolic volume? 93 ml and area is 8.3. This length is 8.3 centimeters. Now I'll move to systole, and moving to systole, I have to move to end systole now. End systole would be end of a T wave. Look, my cursor is come down to end of a T wave. And again, I'll go to the medial annulus, start tracing my borders, and be very careful. You have to do it as many times as possible. Do it again and again. I've excluded papillary muscle to begin with, And this one also have excluded the papillary muscles. So my LV ejection fraction for modified 4-chamber view is 58%. Is that enough for you? And this is modified. Everything is cut up in the like slices of LV segments. So I'm going to move. This is 4-chamber view. Now I'm going to go to 2-chamber view for the same patients. So ask the patient to stop imaging, then go to end diastole. Correct. Go to measure again. Look, it's come end diastole. I'll start with the inferior annulus. Then move my frame to frame. Go to end systole. End of a T wave. And again, inferior annulus. Now look, this is my biplane ejection fraction is 61%. Then 2-chamber ejection fraction is 63%. 4-chamber ejection fraction was whatever it is. So this is what I'm going to look for, 61% biplane modified ejection fractions. Is that clear?
Yes, sir.
Nothing short than this.
Sir.
Now we have talked about systole. So let's say this is mid septum, apical septum, basal septum, apical lateral, mid lateral, basal lateral wall. Do you find any abnormality? Let's see basal septum. Normal, abnormal.
Normal.
Normal.
It's
Normal.
not thickening. Look, it's not thickening. This is thickening, this is thickening, this is thickening, this is thickening, this is thickening. Look, where is this segment thickening? And you just say this segment is not thickening. So what we do, we go to different view and look, this is now normal. So we are cutting a slice of a bread. So there is no focal wall thickening abnormality in mid and basal septum, mid and basal lateral wall, apical lateral, and apical septum. 2-chamber view, very beautiful recording. All inferior wall segments are contracting, all anterior wall segments are contracting. And so is the anterior septum and the posterior wall, they are contracting with. Now at this time, what we do in our lab is we do something more than that. We do that as AFI, and this AFI does everything by itself. Like this is a Mercedes bench. So it tells you, it gives you ejection fractions, along with it gives you a GLS also. So this is what it's calculated. So ejection fraction, it has to be modified. It does by itself. It has to be modified further. It's not comprising of a complete screen, but this is what it's taken in endocardial borders. So we can modify these endocardial borders to get to the same ejection fraction along with the GLS. That's level 2 of those people like who want to learn later on, not right now. So we have this endocardial borders giving rise to a GLS as well as ejection fractions. Let's move on to diastology now. I'm sorry, I'll have to go back to archive and come back to this picture again. So once we have looked for a systolic functions, I'm going to look for diastology now. Now what we have done, we have measured E wave, A wave, deceleration time. So here is the E wave, here is the A wave, here is the E ratio and a deceleration time. Correct? Now we went on to measure E prime septal. So this is E prime septal. We went on to measure E prime lateral. It's a E prime lateral. And then we measure the LA volume index, that is 33 mm. And finally, what we need, fourth parameter, is my TR jet velocity, which is 2.5. So let's one person pick up a paper. Let's see what is my diastolic function in this normal ejection fraction. How do we look at? We look at three parameters. One is the EA ratio, that is 1.20. E to E prime average. So what is my E to E prime averages? Let's see whether the machine gives me or not. It's not giving me E to E prime average. Septal is 11, lateral is 11. So E to E prime value would be what? E wave 74 divided by 11. Almost 7. Correct? 6.9 or something. Then what we need next is a TR LA volume. LA volume index is 33 ml. And TR jet velocity is 2.5 meters per second. So what kind of a diastolic function we are dealing with? Anybody? Normal LV systolic function. And we have taught you diastolic functions. No or yes?
Yes, sir.
Yes.
What did we taught you? All forgotten in 2 weeks' time?
E by A more than 2 will be.
It is more than
0.8,
it's
0.8.
1.2.
0.8.
Yes.
Yes, sir. Grade 1.
What are the four parameters? I've told you the four parameters: EA ratio, E2 prime average, LA volume index, TR jet velocity. Come on, people. Don't tell me, don't make me disgusted. We have taught you a lot.
The TR velocity is normal. Has
2.8. 2.8 it is TR velocity.
normal.
So
And,
what kind of a diastolic function it is?
and E by E ratio should be less than 8. It's normal, so 7.
So what kind of a diastolic function it is?
It is a RCMP side, it is diastolic function grade 3. Grade 3.
So seems to be normal. LA volume. So normal. Everything seems to be normal.
Grade 1 or normal, I think.
All right, guys, you are very intelligent people. So we have to take it accepted. So look, here's the diagram. EA ratio more than 0.8 or between 0.8 to 2 is either normal or grade 2. Average E2 prime is 7. So either 7 comes in this. TR jet velocity 2.8 or less. LA volume index less than 34 cc or less. So we are dealing with normal diastolic function with normal LA volume index. Is that correct now?
Yes, sir.
So you don't have to jump. You have to look at four parameters together to talk about diastology in normal ejection fraction. When we talk normal is more than 50% ejection fractions. All right.
Yes.
So let's move to the next one. This is what the systolic function will look for, TAPSE. So what I've done, I've taken my RV, focused RV array view, and I've done a line across this tricuspid annulus. Look, I've done a line across this tricuspid annulus. And I've measured how much my tricuspid annulus is moving from base to apex. So let me measure for you. I hope I'll be able to do it. .5. What is normal values? Anything more than 1.75 is considered as normal. And this is a very strong parameters for diastolic function. We can do a TDI in the same patients. How do a TDI in this patient is? So now look, my E, this is, if you look at carefully, this is S wave, this is E prime wave, this is A prime wave. So my TDI is almost 11 in this patient. This is 0, 5 and 10 centimeters per second. My TDI is almost 11. Anything more than 9.5 is considered as normal. And my pointer is little bit towards the RA side. So we have two parameters of RV functions. We are going to deal with them later on. At present moment, we talk of TAPSE and RV free wall TDI. Okay. So I'm sorry, I'll have to I've done my measurement stop. Then I have to go to 2D. I'm trying to find out I have to go back to archive again. Go to normal and then Kavya Nathani. All right, let's go to the next pictures. So we have looked at LV functions. And one more point I want to say, how do we look for E prime septal, E prime lateral? Look, this is a tissue Doppler imaging. I'll go my E prime septal, so I'll keep my sample volume at the medial annulus little toward my LA side. Then I keep it a lateral annulus. So this is my E prime septal, yellow color. This is my E prime lateral. E prime septal is almost 7. E prime lateral is almost 8 or 9. And this is mean values. What we do it during live session, that is absolute values. And look, the most important thing, the systolic contraction of the septum and the systolic contraction of the lateral wall, they're happening at the same time. Diastology is happening at the same time. E and A wave almost. So what does tell you? This tells you about synchronicity of contraction of septum as well as lateral wall. Means both the septum and lateral, they're almost virtually contracting at the same time. So let me go back again. And last, what we did in this subject was we looked at IVC. Look, IVC is almost normal. If I have to measure my IVC, I have to measure distal to the hepatic veins. So I'll ask the machine to stop, frame by frame. Correct. There's nothing like systole and diastole. It is before inspiration, after inspiration. So measurement, I'll go to generic and I'm measuring, this is this is hepatic vein is, I'm measuring distal to the hepatic veins. 1.4. Anything less than 12, 1.2 centimeter is considered as volume deficit. More than 21 or 2.1 centimeter is considered as volume loaded. And when it is between less than 21 millimeters, collapses more than 50%, my RA pressure is 5 and mean is 3. Last, This is what the bullseye of this patient is. So his ejection fraction, which we calculated by this bullseye, was almost 58%. And not only that, the same thing which I wanted to show you at that time was not coming up. Now I've done my all 4-chamber, 3-chamber, 2-chamber. This is virtually a global ejection fraction consisting of 3 chambers. Not 2, 1, 2. No, it's including 3 also. And this is what is almost 58% in this patient. 58, 59, thou not in guidelines as on today, but recommended by a certain body, which is considered to be normal. Now, at this stage, I'll ask you to ask me a question as far as normal is concerned. Then I've got a line of subjects today, talking of from a CAD, then cardiomyopathies, restrictive, constrictive, not constrictive, restrictive, hypertrophic, then dilated cardiomyopathy. Any questions somebody want to ask before I move to my next point? This is what you expect to do in every subject. Look, I've shown you everything in my lab. This is how many clips we have recorded. 37 clips. And we have not left anything in this. So let's take a question from Dr. Santanu Mal. Dr. Mal, go ahead.
Yes. Good evening, sir. Firstly, a very simple question, sir. But there's a small doubt, so I wanted to clarify. In the short axis view, opposite to the anterior wall, is it the posterior or the inferior wall?
Just a second. Let me
when
go
is
to
the subcutaneous muscle section, sir? Yeah, in the short axis.
This is septum.
Sir.
Opposite to septum is what would be what? Lateral wall.
Lateral wall. Yes, it's lateral. Yeah.
Anterior septum.
Sir.
Posterior wall.
Okay.
Inferior septum, inferior wall, anterior wall. Look, they'll go simultaneously. Septum, lateral.
Okay.
Anterior, inferior.
Yes.
Anterior septum, posterior wall. So let's go back to the same picture. This is a papillary muscle attached to lateral wall. Opposite to lateral wall is what? Septum.
Septum.
This is
yes.
inferior wall. Opposite to inferior wall is what? Anterior wall. This is anterior septum. This is posterior wall.
Okay.
Clear?
So,
All right.
And second question, sir.
Go ahead.
With respect to the TDI, how did we concurrently place the cursors for the E prime on the the septum and the lateral wall, sir?
Concurrently. This is an acquired image.
Okay.
I've acquired TDI image at the same time. So
Yes.
I can put not 1, 2, I can put 3.
Okay.
Septum, lateral, RV.
Which option from the machine did you go for this, sir, to get this
This is
particular?
Q analysis. Look at the Q analysis.
Okay.
This is there in every machine. Just record
Yeah.
a system with a TDI and just use Q analysis.
Okay. And what was the cutoff for the RV function, when we place the TDI on the RV?
9.5.
9.5. Okay, sir. Thank you so much.
Next is Dr. Veena Yogesh Bang.
Sir, can you please repeat RWT?
All right. Veena, just again, I'll have to go back to my presentation site. This is septum, this is lateral wall. Oh, RWT, I'm so sorry. So RWT, what I've done is, I've cut it. This is parasternal short axis view at papillary muscles. So this is a view papillary muscles. I've done a section across this papillary muscle, cutting across anterior septum and the posterior wall. So this is anterior septum, this is posterior wall. And I'm going to measure it. Then I'll come back to this picture again. So I'm going to LV. Then I'll start measuring from the septum. Look, the picture has to be very clear. Patient holding breath. And then you measure this. Otherwise, you'll haywire the things would be. So that's how you measure diastole of IVS. Then LV dimensions during diastole. Then posterior wall. Then systole of the IVS. Then posterior wall systole. and interventricular septum during systole. And once you have done this, the machine will give you the value. This is RWT. It's already calculated by a machine.
Okay.
What is RWT? We told you about already. 2 into posterior wall thickness divided by LV internal dimensions.
Okay, sir.
And this is mass. So this is less than 42. This is more than 95. The patient belongs to eccentric hypertrophy. Okay?
Okay, sir. Sir, one more question.
Go ahead.
Can you please repeat how to measure TAPSE?
A very simple thing. Go to 5-chamber view. Put a line across it. Let me just try to put a line and mode across it. Now you can see my mode.
Yes, sir.
Very simple. Now you measure. So base, here is the base, here is the apex.
Okay.
2.6, 2.5. That was 2.5 last I measured. Look, I'm just cutting through tricuspid annulus. What is TAPSE? Tricuspid annulus plane systolic excursion.
Yeah. Movement of the.
Correct. And it's a very good parameter.
Yeah.
Believe my words, when we were doing work in COVID, I was using TAPSE, and the second thing I was using MAPSE. What is MAPSE? Mitral annular plane systolic excursion.
Okay, sir.
I'll just show you. Give me a second. Let me just pull it to. Oh. So we got it. So I'm going to measure this. This is again a finding for systolic functions. Obviously, we do not do it nowadays, but this is one thing which I always do when I'm in emergency department or somewhere else. So I'll go and measure my MAPS. That is 9.5. This is 11, as far as I remember. So many values you have to remember every day. Should be 11 or 13, whatever it is. And look, now you can see a very beautiful aneurysm. Intra-atrial septum bulging again toward left-hand side, left-hand side, left-hand side. All right, questions? Shall we move further?
Sorry to intervene, sir, but since you were talking about RWT and LV mass, the condition wherein just the LV mass is increased, we call that probably eccentric LV hypertrophy. The condition wherein only RWT is increased, that is?
Concentric remodeling.
Concentric remodeling. And when both
Both of them are increased, concentric LVH.
Okay, great. And as per some guideline, if I remember correctly, you said probably the British guidelines, they rely on the wall thickness, and the cutoff is something around 1.2.
11 to 12 millimeters.
Okay.
Look, it's a very varied word. Varied in the sense, too many legends. Like, why do we have a mother-in-law in a house when five daughter-in-laws are present? Because mother-in-law will control the complete orchestra. So same happens in this echocardiography. There's so many daughter-in-laws. Everybody start pumping by them. So look, I'm this, I'm this, I'm this, I'm this. So one of the daughter-in-law is British Society of Echo. They say you should measure over here. You should measure over here, and then we'll go to apex. You measure over there. Then they'll come to base. You should measure over here. You should measure over here, and then you should measure in the apex. Anything time more than 12 millimeter, you should consider as hypertrophy. I don't know like how many times you keep on measuring LV hypertrophies. Well, they have a value at certain different places. I'm not saying they are wrong, but not in normal subjects. And whatever IWT has said, this has come into publication by Journal of American College of Cardiology. They are using this LV hypertrophy as one of the parameters for patients in stage B heart failure. All right.
Okay, sir.
Dr. Tajinder Kaur was left behind. I was just expecting Dr. Tajinder Kaur. Why is she sitting idle? Go ahead.
Sir, while labeling a patient as concentric LVH, you have to measure intraventricular septum and posterior wall hypertrophy, and also RWT.
In today's circumstances, if you ask me, I'll do both of them. Whenever I look for concentric LVH, if my RW2 is more than 42 and if this male more than 115, I'll label as concentric LVH, but at the same time, I'll go and look at my various other segments.
Okay, sir. So you have to consider 3 altogether, not.
Correct.
Okay, sir. Thank you, sir.
All right, let's move to the next one. Tell me whenever you want a break, because I'm not going to let you sleep before tonight, midnight. All right, the next one is stage B heart failure. So we are talking of a coronary disease. So let's talk coronary disease first. So I've already talked about normal. Then let me go to CAD first. So in CAD, we have to talk about LAD lesion first. So in LAD, just a second. Yogesh Sharma. No, not this one. Okay. Now, I'm not going to complete case now. I'm going to show you wall motion abnormalities, and then you raise your hand. What is the wall motion abnormalities in this patient? All right. I'm increasing the gain for all of you. So raise your hand. What is the wall motion abnormalities? Prajakta Pote. Great. Prajakta, go ahead. You're the first one.
Apical and apical mainly, sir. Apical lateral.
Apical lateral is what?
Sir, some lateral distal, mainly apical wall motion abnormality, sir.
Prajakta, we talked about basal lateral, mid lateral, apical lateral, basal septum, mid septum, apical septum. So what particular segment we are talking about?
Apical lateral and apical septal, sir.
Apical lateral, apical septum. What they are? Hypokinetic, akinetic, dyskinetic, nomokinetic?
Hypokinetic, sir.
Oh, what do you say hypokinetic?
So there is some motion in apical.
At this point, there's no motion seen in the apex.
Yes,
Yeah.
It's akinetic. Look carefully. You are good, but you are little away from being good. You are little good. So from this point onwards, look, this is thickening, and from this point onward, this whole apical lateral apical septum, along with the apex, they are akinetic. And look, there's a cutoff over here. Look,
yes,
at
sir.
this point, it's contracting, and here is apical septum, apical lateral is akinetic. What is there in it?
So is there a dilatation with a clot? That
There is aneurysm.
aneurysmal
I'll come back. Don't jump in between. Raise your hand, sit ideal. I'll ask you the question. Then you. This is LV apical thrombus.
Yes, sir.
So if it's apical septum, apical lateral wall, what territory are you talking about?
LAD.
It's LAD, sir.
LAD. Great.
Yes, sir.
So we'll stop over here for you.
Yes,
Then
sir.
let me go to the next person. This is democratic word, like everybody should get a chance.
Sorry, sir. If we like cut across an M mode, can we cross check using that in case there's a doubt?
We cannot get an M mode in this picture. All right.
A tangential, maybe
A better picture. Look, this is a very deadly clot. This is organized. This is outer membrane, and this is an empty shell in between, man. This is not a simple clot. All right. There's no second thought about it. I can assure you that. All right. Anybody else? Dr. Santanu Mal was there. He disappeared.
No, so I asked the question about the M mode. Just to, if we cut across
We do not have any M mode in this. How can I get an M mode of this?
I mean, to get an idea of the wall motion, just for that. I mean, not off the
How
record.
can I get the M mode in this picture? Tell me this. How can I get the M mode like this?
I mean, not sorry, sir. I do not mean the entire cross section. Just that particular segment which we want to check the the wall motion of.
Forget about M mode in this era.
Okay.
All right. Somebody will raise a hand. Abnormality. If you not raise, I'll ask the name. Okay. Dr. Muzaffar Naik. What is the abnormality? Oh, Kamal Kishore has come up. Okay, Kamal, go ahead.
Good evening, sir.
Good evening. What is the
Sir,
abnormality?
there is some LA.
We have not got
present in LA,
all men's are
cavity.
still sticking around with the LV.
Okay.
ऐसे मत करो बॉस. आप मेडिकल कॉलेज में मेंस हॉस्टल की तरफ जाते जाते फिर वुमेन्स हॉस्टल की तरफ चले जाते. I'm still looking for a LV. What is this view, Kamal?
So this is a clot in LV cavity, apical.
No, what is this view? 4 chamber, 3 chamber, 5 chamber, 7 chamber?
Okay, so this is 2 chamber view.
Correct. So what is the wall motion abnormality in this 2 chamber view?
So here we see anterior wall and inferior wall.
What inferior wall means? Apical inferior. This is apical inferior. This is apical anterior.
Yes.
And this is large thrombus present in this apical inferior plus apical anterior along with the apex, and they are akinetic. Okay? Forget about LA. I'm not going to LA at all. Now I have to go to 3 chamber view. And Dr. Madhav Bansal had raised his hand. Madhav.
So there is also problem in septum also.
Where was septum, young lady?
No, sir. Sorry, sir. It's inferior wall.
Yeah, this is inferior wall. This is anterior wall. अब सारी रात रामायण पढ़ी, सुबह सीता किसका बाप था?
Sorry, sir. It's inferior wall.
So,
sir, I raised hand to answer the question. Actually, it is already being taken up. I mean,
okay, fine. Now somebody would like to take up this question, or I'll ask somebody's name.
Yes, sir. This is 3 chamber view.
What is your name?
Madhav, sir.
Madhav. Okay, go ahead, Madhav. 3 chamber view.
Sir, this is 3 chamber. This here the LV apex is a kinetic with LV clot, and this posterior wall is moving, and this is anterior septum.
Wait a minute. Basal and mid posterior wall, they're contracting very well.
Yes,
basal anterior septum is contracting. Mid anterior septum is akinetic or hypokinetic. Correct?
Yes, sir.
And we do not label as apical anterior septum or apical posterior wall. So this is basal anterior septum is contracting, mid is hypokinetic. Clear?
Yes, sir.
So what we looked at, 4 chamber view, apical septum, apical lateral, 2 chamber view, apical inferior, apical anterior wall, and 3 chamber view, mid anterior septum along with apex, which are akinetic with LV apical thrombus. So where is the lesion in this LAD territory?
So,
All of us.
Sir, it is distal to LAD.
Wait a minute. Raise your hand. I'll ask you the question. Shahbaz Kareem. Go ahead, Shahbaz.
Sir, it's distal to D1, sir.
Perfect. If it's proximal to D1, what will happen, Shahbaz?
Sir, the basal anterior septum and mid anterior septum is hypokinetic or akinetic, sir.
Correct. So, Dr. Shahbaz has given perfect answer. You know, that is what I wanted to teach you at this moment. Shahbaz, what is your roll number?
Sir, I am in online roll number 6.
Roll number 6, Shahbaz Kareem. Good. So what he said was very correct. If my basal anterior septum is contracting, mid anterior septum is hypokinetic, I'm looking at a branch which is D1 which supplies to basal anterior septum, and my lesion is distal to D1 branch of LAD. So it's not proximal LAD. This is mid LAD. If my basal anterior septum is not contracting, it means I'm dealing with lesion prior to D1 branch of LED. And what do you mean by prior to D1 branch of LED means I'm dealing with
LED.
no proximal LED, that left LED origin.
Yeah.
Give me a second. And this is what is very important in day-to-day practice. If I'm doing an echo in my lab and I can say that which patient should immediately go for angiograms. Immediately means immediately. I don't have a time for that.
Proximal LED.
So this is mid-LED lesion. I'm trying to look for an angiogram. Just give me a second. I'll find out one angiogram and try to solve what exactly I mean to say, tell you. And those people who are sitting in a villages, those people who are at peripheries, and those people who are dealing with these kind of a subject in the midnight. Look, it's very important. We have to react very fast. If I have a proximal LED lesion, this is very difficult to thrombolize those patients. If it's a mid-LED lesion, it's good. If still apex is involved and the mid-anterior septum is contracting, the lesion is distal to LED lesion. Distal to D2 branch of LED. It means it's a distal LED lesion. Thrombolize, relax. And that's what I wanted to convey with this picture. Echo is one modality which can change the complete scenario of your practice. I'm not able to locate my angiogram films enough because just a minute, they should be somewhere. A lot of work is going on. Images, drivers. Yeah, got it. I hope I should be able to show you these pictures and you'll realize that all right. So what do I do is make it short, go, dilate, share, and I think I should be able to show you a picture. Can you see my angiograms?
Yes, sir.
Yes, sir.
So this is LED, this is circumflex. And once the LED originate, it's a D1 branch, this is D2 branch. If the lesion is at proximal level, the basal anterior septum will be out. If the lesion is distal to it, then we have a D2 branch and distal LED. If the lesion is further distal to it, means further mid-anterior septum is also saved, then we're talking of distal LED. We're not bothered. If it's a distal LED, apex is involved. Who bothers, yeah? We'll do thrombolysis. But if the lesion here, believe my words, is the most deadly lesion you ever have in practice.
Angiogram is not moving.
Yeah, we are not able to see that.
Now angiogram is moving. I did deliberately stop the answers. Now it's moving.
Yes, sir.
We just have the preview, sir, but
Yes,
it's
sir.
not opening. Yeah, it's just the preview, the small preview.
Can you see it now?
No.
No, sir.
No, sir, only the thumbnail still.
All right. So that's how I should be able to show you, because sometimes it does not pop up in these pictures. So are you clear what I mean to say is?
Yes, sir.
Give me a second. The computer is taking a time to. The computer is not tuned to so much of a sudden changeover from one topic to another topic. It gets bumped up completely.
So do you mean that mid basal is mid basal septum is being supplied by D2 and basal septum is being supplied by D1?
Not basal septum, basal anterior septum in three chambers.
Basal anterior,
No,
basal
there's a lot of
anterior.
difference. Basal anterior supplied by D1, mid anterior septum supplied by D2, and then distal. If the basal anterior septum is involved, proximal LAD lesion. If the basal anterior septum is spared, then mid anterior septum. If basal and mid are spared, then it is a distal LAD. All right. Is that okay or not?
Yes, sir.
Yes,
Okay.
sir.
Say yes is good.
Yes, sir.
Yes,
All right. Let's go to more now.
Fabulous.
So let's talk of RCA lesions. This is Shehnaz 4027 CAD. You can see my screen.
yes, sir.
Yes,
Okay.
sir.
All right. Straightway I'm jumping to wall motions. I'm not going to look at anything else. 4-chamber view. Raise your hands. Oh, Mother Bansal, go ahead, Mother.
This is basal IVS.
I don't know. I have not taught you basal IVS till date, man. What do you mean by basal IVS?
Sir,
Basal septum.
Basal septum, sir.
Hypokinetic, akinetic, dyskinetic, normokinetic.
Hypokinetic.
Hypokinetic. Good. So, which territory this septum belongs to? Basal septum belongs to.
RCA.
This is RCA.
RCA. Good. So, I'll let your hand be down. So, Madhav is done. So, let's take the next one. Dr. Ravi Kumar Nimala.
Yes, sir.
Go ahead, Ravi. Tell me what's there seen in it. All right, I'll show you one more picture.
There is a gross left ventricular hypertrophy, sir.
Boss, I'm asking the wall motion abnormalities. You're telling me the wall.
Wall motion abnormality is basal septum, sir. No, not basal. Apical septum. Apical septum.
There is no. What view this is?
Sir, this is two-chamber view, sir.
In two-chamber view, what are the segments? What are the walls?
Anterior and lateral.
Interior septum.
Wait a minute. Let him do blunders, you know. Dr. Ravi Nimala, where are you, man? In which word, where are you? Look what will happen tomorrow. Ravi Nimala will say two-chamber view has got septum. Everybody will drop dead. If you say second time, the next person in the hospital will drop dead. In 10-chamber view, we have this anterior wall, we have inferior wall. So what is the abnormality in this two-chamber view? We have an exam next week. Ravi, where are you located?
Yes.
Which place are you located?
Guntur, sir, Andhra Pradesh.
I'm a pass out of Warangal Medical College. At least don't spoil the name of Andhra. Yeah.
Yes, sir.
So what is the abnormality in this? All right, you can't answer it. Let me go to the next person. Then we have Abhijit More. Abhijit, go ahead.
Yes, sir. Two-chamber view, mid and basal inferior wall is hypokinetic.
Which wall is hypokinetic? Which
Mid and
segment?
basal inferior wall.
Mid and basal inferior wall is hypokinetic. He says mid and basal inferior wall is hypokinetic. Dr. Priya Bhatta, do you say that? You agree or you disagree?
No, sir.
You're not agreeing? So what segment is abnormal in this patient?
Basal inferior wall, sir.
Basal inferior wall.
Basal inferior wall.
All right. So one person says mid inferior wall, the second person says basal inferior wall. Though how do I say this segment is correct or wrong? All right. Suppose there is a mid inferior wall is involved and basal inferior wall is also involved. Then what will happen in this patient? Anybody?
MR.
Oh, what's your name, man?
Shahbaz Karim, sir.
Shahbaz Karim. Where are you, Shahbaz?
So right now I'm in Purnia, sir. Purnia, Bihar.
बहुत सारा आईएएस का दिमाग वहीं से आता है बिकॉज बिहार में कुछ स्पेशल है
थैंक यू सर
अच्छे काम के लिए दिमाग वहां से आता है बुरे काम के लिए भी वहां से आता है Look, if this patient has got a mid inferior wall involved in the region of papillary muscles, means it'll have papillary muscle ischemia, and the patient will have what? MR. Correct?
Yes, sir.
So the person who was saying mid inferior wall, he was right. And if it's only basal inferior wall, what will happen? There will be not any significant.
No MR. There will be no MR, sir.
No significant. I don't say no MR. There could be some
no significant MR.
but there will not be any significant MR. Look, it's significant MR is present. This is at least moderate. It may be more than that. Wonderful. Shahbaz, I'm really impressed with you.
Thank you, sir.
All right. Now, last question comes. If my mid and basal inferior wall is involved, mid and basal septum is involved, and I have to see my three-chamber view also. Wait a minute. Anything in three-chamber view? Anybody raise your hands? Dr. Shahbaz, you hold on. Don't raise your hand.
Okay, sir.
Tajinder Kaur, go ahead, Tajinder.
Sir, basal septum is hypokinetic.
तजिंदर नाइट हो गई है सोने का टाइम हो गया बेजल सेप्टम कहाँ से आ गया
थ्री चैम्बर व्यू
तो यहाँ बेजल सेप्टम है कौन सा वाला बेजल सेप्टम है ये वाला बेजल सेप्टम है या ये वाला बेजल सेप्टम है
नो सर दैट इज पोस्टीरियर वॉल
व्हाट इज दिस
एंटीरियर सेप्टम सर
बेजल सेप्टम कहाँ से आ गया
यस सर दिस इज एंटीरियर सेप्टम
अरे अभी तो सर रामायण पढ़ा के चुका हूँ सारी की सारी एलईडी की So mid and basal posterior wall, they appears to be hypokinetic to akinetic. ऐसे नहीं करो आप देखो अच्छा नहीं लगता बिलीव माय वर्ड्स बहुत मेहनत होती है पढ़ाने के लिए बहुत ज्यादा मेहनत होती है I've spent about 4 hours today in the afternoon to use I'll say which picture I'm going to show you. I've organized my complete Lacopac today. 4 to 5 hours, maybe more than that. All right. So mid and basal posterior wall is involved, mid and basal inferior wall is involved, mid and basal septum is involved. So which territory are you dealing with? Before that, I'll show you my right coronary artery territory. RV is contracting normally. So which territory, Lavkesh? Circumflex, possibly circumflex, but it could be either. I'll not put my bet only on circumflex because I'm seeing my lateral wall is contracting very well.
Yes, sir.
So I'll possibly say RV, distal to RV branch, which is dominant vessel. Because posterior artery arises from right.
Yeah, PDA is from right.
Correct. So we are dealing with RCA with dominant PDA. Okay? Comfortable, non-comfortable?
Comfortable, sir.
Okay. Any questions before we move to the next one? All right. So we have seen CAD, we have seen RCA, and now I'll show you one more CAD, and that's a very rare CAD which we see in our day-to-day practice. Let me show you a couple of examples of a clot first. So that you don't forget about clots. Whenever you see an apical wall motion abnormalities, always look for a clots. Always look for a clots. So you look for a clot for 4-chamber view, 2-chamber view, and a 3-chamber view. And rotate your, make your offshoot views, foreshortened views to look at a clots. Because in LAD territory, there are very high chances of having clots. So my question is, this patient has got a clot or no clot? I'm sorry, this is something wrong happened. So my patient has got a clot or no clot? Look,
Yes,
is
sir.
it LAD territory? Who said yes, sir?
So,
What's your name?
Sir, Shahbaz, sir.
Shahbaz Karim. Clot is there? Good. Where is the clot?
Sir, it's just lateral in mid-lateral wall, sir, near
There is
the.
a linear apical thrombus in relation to apical lateral and apex.
Yes, sir.
It's here. Look, endocardium is over here.
Yes, sir.
And the clot is over here. Let me show you if I can show you with the colors.
Very lateral something.
Look, I'm changing colors of the machines. So here is a linear apical thrombus.
Yeah, linear apical thrombus, sir.
And then you have to see it in its two views. Now it's seen in here also. All right.
Yes,
so you have to hunt for it. They'll not come straight forward to you. We have seen this Pankaj Chablani. How many clots? Raise your hand. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
4. It's 4, sir.
3 clots, sir.
4, sir.
It's 4, sir, I think.
3 clots.
Is this man should be happy or unhappy? Or doctor should be happy or unhappy?
Happy, sir.
If this is my patient, I'll run away virtually. Believe my word, I'll be very unhappy.
Yeah, I'm happy, sir, being a doctor.
This is a necessary band.
Yes, sir. This is aneurysmal rupture, I think so.
This is apex. Here is a clot, linear apical thrombus. The problem is there is one clot which is hanging from this point over here. And this clot is likely to displace out any time. It's just hanging with a thin stalk.
Yes.
I'll show you many pictures of this patient.
Clot can cause CVA.
It can cause anything. What to talk about CVA? It can cause anything, man. Believe my words, if I happen to see this kind of a patient, that is the most deadly. Look, now you can see a stop. I'm changing views now one by one. Thin stalk is hanging. I'm not bothered about this clot. There's some clot over here, deposition over here also. But this is hanging in thin clots. Thin stalk. Very unhappy. I'm not really happy with this patient. If it mobilized, believe my words, it'll go either in the lower limbs or it'll go in the brain. Lower limbs can still be dealt with. The brain is very difficult. All right. Now, this is a patient of acute interval MI. You saw a patient who had an akinetic segment. Now, this is a patient of acute interval MI. MI is just a few hours back. What is the difference between this patient and other patients? Look, you may not be knowing about it, but let me tell you, this is
the myocardium is, I think, a bit variable. Myocardium is a bit variable. So if we do any coronary intervention or somewhat like a thrombolysis, it will be profitable for the patient. So
no. But what I wanted to show you, if you look at this endocardium is, let me just stop this picture for you. Somebody was asking, that's what I'm trying to show you.
okay, sir.
Now is the time to measure the endocardium. Seven millimeters. This is in diastole. I'm not talking of this is in end diastole. So it's almost 7 millimeters. It's not thinned out.
Yes,
it's not hyperechoic. Look at this LED territory. Again, I'll come back to it. Look, it's not hyperechoic. So this is acute interval MI where the preserved endocardial thickness is present. And if you happen to see a preserved endocardial thickness, this is patient where you could expect a viable myocardium.
Yes, sir. That is what I try to say, sir.
Now you can see much better over here. Look, the endocardium is still seen very good over here. Yeah. So that is what is known as viable myocardium, preserved endocardial thickness. I should be able to show you one more, the same one. Nathya Devi. Yeah, beautiful. Now you can see much better. This is LED, which is contracting. This is akinetic lateral wall.
Yes, sir.
But you could see a preserved endocardial thickness.
Yes, sir.
Now you can see a better preserved endocardial thickness.
Yes, sir.
Now it is better. Now you can see a preserved endocardium. Now I can stop it and measure it for you. Some people were not happy last measurement. So I'm end diastole. I'm going to measure it for you. Now you can measure as many places as you want. 1, 2, 3, 4, 5. Very good endocardial thickness. And patient is akinetic. This is not normokinetic. This is akinetic. Can you see this? Will have MR or not?
Sir, we have MR because the
severe torrential MR. Now you can see a severe torrential MR.
Yes, sir.
Papillary muscle dysfunction.
Papillary dysfunction. But
Vena contractiva 0.85. All right, guys. Good. So lateral wall, Now you can see much better endocardial thickness. Now we should see posterior wall. Same. Look at how beautiful hypercontractile LV is. And look at the akinetic posterior wall. Circumflex, 110% circumflex. Dominant PDA.
Dominant PDA.
All right. One image, and then we'll switch over to other things. Wall motions, raise your hands. Good. Dr. Ravi Kumar Nimala, first of all.
Sir, the lateral wall, the apical lateral, mid lateral, and the basal lateral wall are hypokinetic. The two akinetic, sir.
Dr. Shahbaz Karim.
Yes, sir. The basal septum, mid septum, as well as the apical lateral wall and apical septum is almost the basal and mid septum is akinetic, so and the lateral the mid lateral and apical lateral is hypokinetic, so
Well, this is contracting. This is contracting. This is contracting. This is akinetic. Mid and basal septum is akinetic. Hyperechoic. Correct? So if mid and basal septum is akinetic hyperechoic, what kind of a lesion do we expect?
it's LED.
Septum. Mid and basal.
D1.
RC.
D1.
D1.
RCA.
I'm going to sleep, man, now.
RC. sir.
RCA.
RCA.
RCA reason, sir. It's right contact reason, sir.
RCA, sir.
Correct.
RCA reason, sir. RCA reason.
So septum is involved. I hope you're not tired right now.
Sorry, sir.
Mid and basal septum is involved is RCA. And if RCA is seen, what segment you will see in inferior wall? Look at the inferior wall, which is akinetic.
Mid and basal.
If it's basally involved, then you look for MR.
Yes, sir.
So we look for MR in other views. Look at the MR. Now the question is, this is one MR and there's one more MR in this patient. And this MR is originating between tricuspid and mitral valve leaflets. It has created ventricular septal defect in between in the AV group.
Yes, sir. It's mechanical complication of
Mechanical complication. This is known as Gardner syndrome.
yes, sir. VSR.
VSD over here. This is unusual kind of a VSD originating between AV group. The groove between tricuspid and mitral annulus hinge point, it is originating from there. And this is the deadly thing. This patient you cannot say ideal. Gradually they'll go in shock.
Yes, sir. Failure as well as in shock.
Correct. So I'll put my stop over here for CAD. Done. Enough for CAD. Now move to cardiomyopathies. First cardiomyopathy is dilated cardiomyopathy. So let me see which one I have located. Nathya Devi we have shown. Then, all right. This is first is ischemic cardiomyopathy. This is patient 13089. 13089. All right. Moving from CAD to cardiomyopathy. What is the difference between CAD and a cardiomyopathy? Raise your hand. All right, Dr. Veena, go ahead.
Sir, if the etiology is ischemic, means there is any occlusion of the vessel and that is leading to the dilatation of chamber, then we call it as ischemic.
Correct. If the difference between CAD and cardiomyopathy is, in coronary artery disease, we'll find a normal LV size and shape. In coronary cardiomyopathy, we'll find a dilated LV sizes or LA sizes. That's what I wanted to show. So this patient has got a dilated LALV and has got associated with basal septum, which is akinetic, almost akinetic. I'm going to show you the lights. Now you can appreciate better. Gains. Now you can see better now. Say yes or no.
Yes, sir.
Yes, sir.
So L dilated with inferior segment abnormality. This is 4-chamber view, and look at the beautiful IS aneurysm. Let me just stop and tell you what is IS aneurysm. Sometimes we see it and we should not miss in measuring it. All right.
This is
So,
IS.
IS aneurysm, like we draw a line in the center, then a measurement from this point. Anything more than 1.5 is considered as aneurysm. Is almost 1.1. So this is how we measure IS aneurysm. It could be left-hand side, it could be right-hand side, it could be either of the side or both of them. So we see basal inferior wall, which is akinetic. Now we can see it's much better. Then 2-chamber view, same thing, basal inferior wall. That was basal septum, I'm sorry. This is basal inferior wall. And now the basal posterior wall. So this is patient presenting with compensation, no chest pain, nothing, but the patient is breathless. And now this is already compensated, and this is known as ischemic cardiomyopathy. And once you look at the ischemic cardiomyopathy, then what you should do is you should do a tissue Doppler imaging. I don't say whether it's dilated or ischemic. So what I'm going to do, I'm going to do a tissue Doppler imaging. My medial annulus should be more than 7. All velocity should be more than 7. I showed you earlier. So medial is 6, 5.94. Lateral is 8, normal. Medial was reduced, lateral is in normal. Then we have inferior, which is 6.57, again reduced, and the anterior is normal. And now we have a posterior is annulus 8.5. If you look at this, your septum TDI is reduced, your inferior TDI is reduced, and again suggestive is that we are dealing with abnormality of septum as well as inferior wall. If it's a dilated cardiomyopathy, all velocities will be uniformly reduced. And not at your level, but this is what the bullseye pattern is. If you look at this bullseye pattern, septum, anterior, and inferior wall, this is all reduced, and these are normal. This is the cutoff values minus 17 or minus 18. So all these segments are significantly reduced. I'm not talking at your level, so let's not go more on this. So that is what is ischemic cardiomyopathy. What is the difference between CAD and ischemic cardiomyopathies? Anybody will raise their hands. Coronary disease, patient present with chest pains. Cardiomyopathy, majority of patients will present with breathlessness or angina on exertions. So symptomatology would be a little different. Acute chest pain, acute phenomena. Cardiomyopathy is a chronic phenomenon.
Mainly heart failure.
Heart failure. All right, same patient now. I'm sorry, I have to show you one more in this patient. She was 13089. All right. Now, in this patient, I want to look at my diastology. So I'm going to do my EA ratio. Now, somebody can pick up a paper. I'm not saying no to you. I'm talking of a diastology now. The EA ratio, E wave is 53, A wave is 64, ratio is 83. Correct?
Yes,
Now
sir.
let's how to do it. Right. Next is E prime septal is 5. Lateral is 9. Average is 7.18. Correct? And what we need next is the LA volume index. It does not have an LA volume index. Nothing like a word report out here. Yeah. Wonderful. So LA volume index over here is 28 ml. And the TR jet velocity is TR max is 2.321. Clear?
Yes, sir.
Yes, sir.
So we go to images again. So what kind of a diastolic function abnormality we are dealing with?
Grade 1.
It is grade 1
Grade
impaired
1,
left
sir.
only, sir.
Grade 1. How did you
Yes,
calculate?
sir.
How did you do it, man? So I'll go back to my presentation on diastology.
The normal.
Normal है.
Yes.
कौन बोल रहे हैं आप?
Dr. Tejinder, sir.
Tejinder. Okay. Tejinder, if you have a wall machine, you cannot have a normal diastolic function. First of all, always it has to be grade 1 or more. Just think of that phenomena. I'm just coming down. Give me a second. It is unfortunately, fortunately, the guidelines have changed only this month only. Maybe we are talking in the next session something different. So this is slide number 128. So, इतनी सारी डॉटर इन लॉज है कि कोई सुनता ही नहीं है. सब अपनी अपनी गाइडलाइंस बनाने में लगे हुए. All right. Can you see my slides? Yes or no?
Yes, sir.
Yes.
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
This is reduced ejection fraction. My
Yes,
E
sir.
was 93 and A wave was 64. Ratio was 0.83. So EA ratio less than 0.83. So if I'll go over here, then it'll be a grade 1 normal LA pressures. EA ratio 0.83. So we are not over here. So neither my E wave is less than 50 nor my ratio is 0.8. I'm over here somewhere. My EA ratio is 0.83. E wave is more than 0.50. 53. So I belong to this category. Now I look for E2 prime average. Average is more than 14. So mine was 7.18. TR jet velocity was 2.3. Even this is not there. LA volume index was 28. So 2 are negative, rather 3 are negative. Then I belong to normal LA pressure grade 1 diastolic dysfunction. I'll repeat again. My E wave was 53. So I cannot classify into this. I'll classify into this. EA ratio was 83. So I'll classify into this phenomenon. EA ratio 0.822. Then I look 3 parameters. Average E2 prime ratio was 7.8. TR jet velocity 2.3. And LA volume index was 28. So all 3 of them negative. This is only 2 negative. I said all 3 of them are negative. 2 of 3 or 3 of 3 are negative. Then we belong to grade 1 diastolic dysfunction in normal patients. And what do you mean by grade 1 diastolic dysfunction in normal LA pressure is? It means my LA pressures are almost normal. So they're just borderline, 10 millimeters or more. So if these LA pressures are normal, I don't have to increase my ACE inhibitor or diuretics to reduce my LA pressures further. All right. There is one more variety of dilated cardiomyopathy where the LV size is normal and patient is comfortable. And that patient is 12948. 12948. Now raise your hand if you find anything abnormal in this. Look, there is LV dysfunction in apex. There's some dysfunction in the lateral wall. So LAD, circumflex. Look at the LARA size. They are almost equal. But LA size is not increased. LV size is not increased. Look at the LV size. No, it's increased. So I'm sorry. This is different one. So we have a variety where LV size is normal and LA size is normal. And we have a war machine of abnormalities. And we call them as non-dilated cardiomyopathy. Non-dilated cardiomyopathies. And this patient was classically of triple vessel disease. LAD, circumflex, and if you go to two-chamber view, you will find akinetic mid-septum. Even apex is gone. So if you happen to find, and this thing is very common in postpartum cardiomyopathies, LV-LA size you will find normal, but LV function is reduced. In those cases, you will find LV function is close to 50%. And those are the patients who are in cardiomyopathies. And
even in myocarditis also, sir.
Myocarditis also.
Sir, why it is not ischemic then, as we are getting?
This patient is ischemic, no doubt. This is triple vessel disease. We did an angio, it came out to be triple vessel disease. We have managed her medically. I'll show you sometime her post now. We have done an echo recently. Her LV function is almost normal. And she had, if I remember, she had MR. This MR has disappeared completely. Sizes have become almost normal. So we have Kalpana, postpartum cardiomyopathy. She is 12512. This is classical postpartum cardiomyopathy. Look, LV is dilated, LA is dilated. You see a pericardial effusion out here. And it will be very difficult to appreciate for wall thickening abnormalities in this patient. So you have to look at clinically, what are you looking for? That's the most important thing in this subset of populations. All right, let me move on to important thing is hypertrophic cardiomyopathies. One very interesting patient, unfortunately we lost him because I kept on telling them to go for AICD. They did not listen. And one fine morning, the patient disappeared. Anybody would like to comment? This is hypertrophic obstructive cardiomyopathy. I can tell you that already. But what do you see in this picture?
So there is a
You have to raise your hand.
dynamic
You
jet.
have to raise your hands.
Yes, sir. I'm Sabas Karim, sir.
Okay, sir.
Yes.
What do you see in this patient?
So there is some turbulence near the LVOT, sir.
Okay.
Yes, sir. There is some dynamic like jet is there over, sir.
No. This is a very classical thing. Now I'll show you more classical picture. If you're not able to answer, Veena will answer.
Posteriorly directed MR.
MR, sir.
Oh, Veena, look, the very important thing is I'll stop this image and show you what exactly is happening in this patient. Look, I'm going to beginning of systole. Systole, systole, systole. Now see, there's an arrow over here, QRS complex. There's a turbulence in systole in LVOT, correct?
Yes, sir. Yes, sir.
Now next thing, see, there's a mid-systolic MR. So at the same time when the turbulence is happening in systole, the MR has started appearing. Why it's happening here? AML is sucked into LVOT. Now mitral valve is left open.
Okay, so
LVOT. At the same time, there's a MR which is present. Now see, the picture is running now for you. Can you see this?
This is systolic anterior motion of middle valve, sir.
Sam?
Yes,
When Sam happens.
Sam.
Now look at the Sam. I'm just trying to show you a picture for Sam.
Yes, sir. This is Sam.
No, this ECG gating will help you. All of you do not put an ECG gating. I'm going to stop it for you. Now, beginning of systole, correct? When does the mitral valve open? Systole or diastole?
Still.
Systole, right? Tajendra?
Diastolic.
Somebody said systole.
And systole, beginning of diastoles.
Now look, in systole, what has happened? The AML leaflet tip has gone into LVOT. There is obstruction to LVOT.
Yes, sir. There is
correct? Now, I'm moving at systole. Now this leaflet has come back. Look, the leaflet is coming. Now this is almost end systole. The leaflet is touching the LVOT, sigmoid septum. Look at this over here. Now I'm moving to systole. Now leaflet has come back. And now I'll go back again. Now it's open up. 2 times movement of mitral valve leaflet. Now see in motion.
Yes, so that way it leads to malcoaptation of the mitral valve.
No, this is not malcoaptation. This is systolic anti-motion of mitral valve leaflet, man.
Yes, sir, Sam.
Nothing like malcoaptation. This is definite hypertrophic cardiomyopathy. Look at the septum, look at the posterior wall, more than 2:1 ratio. Sam, and look at the apical dilatation now. Because of obstruction, the apex has started dilating.
Yes, sir.
You cannot find a better image than this for any hypertrophic cardiomyopathies. Now look at this. Turbulence.
Yes, sir.
Soon after turbulence is LVOT gradient and MR, mid-systolic MR. Gentlemen,
So
no,
we are in every SAM we are getting such type of MR, sir. Very frequent we are not getting such type of MR in, but the patient is having SAM, sir.
patient is having SAMR. If you're not getting a MR, it means either SAM is not there or MR is not there.
Okay, sir.
Think of a thing here. If the mitral valve leaflet is sucked into LVOT, the mitral valve remains open. अगर आप घर का दरवाजा खुला छोड़ दिया होगा रात को, चोर घुस जाएंगे नहीं घुस जाएंगे?
Yes, sir.
So if the AML is left open, AML goes towards LVOT, what will happen to mitral valve? It'll get opened up.
Why it is sucked?
Why sucked? All right. Who are you? Can you identify yourself?
I am Dr. Veena Bang.
Veena, have you ever stood on a platform in your life? Have you gone to the railway platform?
Yes, sir. Yes.
There's a line on a railway platform.
Yes, sir.
That line.
We have to stand away from it.
Correct. Why do you want to stand away from that line?
Train will come. So I have not tried it anytime, so I don't know.
No, you don't try it. Then we'll not see Veena anymore. The line is there. When the train moves at a very fast speed, it sucks you towards it. So same thing happens when the LV contracts. This thickened septum will start producing obstruction, and because the pressure gradient of LV is 120 and 30 millimeters of mercury, they drive through LVOT. Though they suck the AML into the cavity because of septum posterior wall ratio. Septum is so thickened away. So it sucks AML into LVOT cavity and leave the mitral valve remain open. And when it sucks, it produces obstruction. And when it produces obstruction, it produces dynamic LVOT obstruction. Look at the gradient. 3.5, 45 millimeters of mercury. And this is without any maneuver. Look, this is not aortic valve. This is slow acceleration over a period of time. Look, it started systole over here, and the gradient developed till end systole. And sharp deceleration. This is inverted comma shape, inverted key shape, or dragger shape, or cookery shaped. Look, now seen more beautifully. So this is LVOT, dynamic LVOT gradients. The gradients are almost 65 millimeters of mercury. There is a SAM. There is a mid-systolic MR. There's a dynamic LVOT gradient. There's a LVOT ratio, septum versus posterior wall ratio more than 2:1. And this is even the cavity in between is also getting obliterated. And there cannot be a better example than this hypertrophic cardiomyopathy.
So this is mid LV hypertrophy.
I'll show you mid LV hypertrophy. Give me a second now. All right. That was mid cavity hypertrophy. I'll show you a picture of apical hypertrophy. Light. All right. Can you see this now? This area is opened up. This is lateral wall, this is septum. And here's a cutoff. This is apical hypertrophy, variant of hypertrophic cardiomyopathy. Now you can measure. I'll stop for you. Now you can measure your septum. Apical septum. (21 millimeter). Anyway, system is not working. So we can see this. This is apical hypertrophy. Now you can see it's much better. Go to 4-chamber view, one more images. Look, it's apical hypertrophy. Now you can see in 2-chamber view. This is anterior. This is on the 4-chamber. Apical hypertrophy. 3-chamber view. Now you can see beautifully. Can you see this? All apex is hypertrophy. This area is well up. Now look, this is not moving into LVOT cavity. This is a variant of hypertrophic cardiomyopathy. These people, they often present with symmetrical T wave inversion in anterior leads. Yeah. Now, this patient has got apical hypertrophy now. Bases are spared. And look at the gradient in the apical hypertrophy. Now the gradient is at this level or this level. Here is the gradients. They're not at the level of bases. They're at the level of mid cavity. Now you can see it's much beautiful. The gradient is right over here. If I switch on my colors, I can switch on the colors, I believe. The cavity is over here. And if I put my cursor over here, I'll get LVOT obstruction. Now look, the gradients I'm getting is over here. And in fact, I'm getting two gradients. Dynamic gradients. One gradient at mid cavity, second gradient is LV apical gradients. Not at the level of base. Look, there's one more turbulence in the apex. One turbulence over here. So I'm getting two LVOT gradient, two gradients in LV cavity. One is over here, second is over here. So this is mid cavity obstructions. All right. So we have shown you everything. So what is left is Shivpati. There is one very good picture, I believe she says is 8443. Yeah. Now the gradients are right in the mid cavity. And look at the amount of gradients. Almost 27 millimeters. Now look at the picture. The great cavity is in the mid cavity, which is getting obliterated. Switch off colors. Mid cavity obstruction. Let me just improve the pictures. So you find so many things in this hypertrophic cardiomyopathies. One last is left is restrictive cardiomyopathy. 12720. 12720. What is the most common cause of restrictive cardiomyopathy? Anybody?
Amyloidosis.
Amyloidosis. Good. Amyloidosis is rare. What is the commonest? Dr. Muzaffar?
Old age.
Pardon? What is the answer, Muzaffar?
Huh?
Commonest cause of restrictive cardiomyopathy.
Amyloidosis.
Amyloidosis is common, but atrial fibrillation is the most common cause we see every day in day-to-day practice. Atrial fibrillation is a variety of restrictive cardiomyopathies. Now look at the most important thing. LA, RA dilated, LV, LA normal. Some more pictures. So when you happen to see LV, LA, they are dilated. LA, RA, they are dilated with normal LV, RV. then think always of restrictive cardiomyopathies. And they'll have both MR and TR because there's no coordinations. And if you put a Doppler flow pattern, it'll be restrictive. That's why we call them as restrictive cardiomyopathy. And many patients, they have LV apical obliterations. And why we call them restrictive cardiomyopathy is because the flow is restrictive. This is a grade 3 diastolic dysfunction. Look in atrial fibrillation, what kind of flow we'll see. There are a couple of things we'll see in atrial fibrillation is, we look at 3 parameters which are very common in atrial fibrillation. We look at E wave. Somebody can take a paper. E wave is 0.72. Then we look at E prime septal. E prime septal is 9. And then we look at flow propagation velocity. What we do is, in colors, suppose this is a colors, I'm going to put an M mode. Now, this is M mode right into the colors. Right? Once I put a M mode, what we see, this is diastolic flow, this is systolic flow. So initially there is A wave, E wave, there is no A wave because patient is atrial fibrillations. Then what do we do? Let me just look at this same picture which I've drawn from here. Look, there's only one wave which is seen over here. There's no A wave. So we take a measurement, we increase the sweep speed to 100. Let me just see if I can increase the sweep speed to 100. No, it's not there. So, but I measure the slope caliper. I start with the opening of mitral valve level and go 4 centimeter up along with this line. So I'm going 4 centimeter up along with this line. And what is the line is? This line is the interface between red and blue colors. So this is the interface between red and blue color. I'll go along with this line for almost 4 centimeters. 3, 4, 4, 4. So it's almost 55 centimeters per second. Clear? So this is atrial fibrillations. And in AF, when we do not have A wave, we use 3 parameters: E wave, E prime septal, and EVP ratio. This is flow propagation velocity ratio. E to E prime septal ratio more than 1.5. Then EVP ratio should be more than 3.4. And that's how we calculate their diastolic function abnormalities. The basic feature of restrictive cardiomyopathy is dilated LA, dilated RA, and normal LV, normal RV. One more picture. I'm sure all of you must be tired. It's more than 2 hours. So let me see one amyloidosis which I have with me. Yeah, it's there. Now, if you look at carefully, this picture is what do you see in this picture? What is the most important thing in this picture?
Sir, RA and
Look at the LARA hues.
Both atrial node.
Normal LV, normal RV. Correct? And everything is so brightened. I don't know any one of you have seen Magnus Gold. It's about 1970 movie. It's a Gregory Peck movie was there. They were looking for diamonds in a valley. And somehow they reaches to the valley in the night. And when the light falls during the daytime as the sun arises, the light falls on the diamonds. It was all brightened up. Look, this image is all brightened up. Thickened tricuspid, thickened mitral valve, thickened interventricular septum, thickened lateral wall, thickened RV free wall. And they're showing you something. Look, brightened look is there. And this is NSR. This is not atrial fibrillation. And if you look at an NSR, look at the parameter of diastology. Those parameters of diastology will show you that this is typically of a restrictive filling pattern. Means grade 3 or more filling patterns. Look at the mitral valve. Although it's not taken properly, look at the mitral valve. Tall E's and very small, tiny A wave. And this is ectopic activity which is going on. This is not normal sinus rhythm. This is 3 different like running beats of a ventricular ectopics. This is NSR over here. You hardly locate an A wave. This is all like this is just a tall E wave, a very small, tiny E wave. A wave. The patient is in restrictive cardiomyopathy. Severe MR, severe TR. And if you happen to look this picture ever in your life, look, there cannot be a better picture than this. And obviously, these functions, they start falling over a period of time. The pericardial effusions start collecting. And when the pericardial effusions start collecting, LV functions start going down. These are people who have got a very bad outcomes. And when you look at an hypertrophy, these hypertrophy will not have LVH. ECG would be normal. And this is very classical sign of amyloidosis, apical sparing. This is a very advanced phase. Even the apicals, look, this is positive deformation. It means when these segments are contracting, these segments are relaxing. And these are still contracting, but normally 17. So initially these segments, apex would remain normal, but gradually the apex will start going down. And fall. Look at the apex has started falling down. Look at the pericardial effusion the patient has got. If a amyloidosis patient gets a pericardial effusion, the end is very close. So you'll not forget this amyloidosis in your whole of your life. Look at the short axis view. Now you can measure your septum thickness all the way around. All pericardial effusions started collecting over here. Look at the brightened. Very interesting. Look at this echogenic focus, like these small, tiny calcification kind of a thing in the septum and posterior walls. Very classical of amyloidosis. And whenever you see LVH without any significant ECG changes, always think of some deposition disease. That's how we differentiate hypertrophic cardiomyopathy, hypertensive heart disease versus deposition disease. So I'm all done. Any questions? I've showed you everything, systole, diastole, and variability of a diastole. If anybody has got a question, kindly raise your hands.
Sir, I have one question.
Go ahead, Ina.
Actually, it appears to be a little silly question, but I still want to ask.
You know why? Somebody who got a Nobel Prize or the invention of that was Newton. You know, he started thinking why the apple was falling down, why not going up in the sky. So no question is a silly question.
Sir, in last couple of images, we can make out that RA and LA are dilated, and there we cannot trace the complete septum. So when some patient comes to us and we are not able to trace the interatrial septum properly, and dilated RA and LA is there, so why it is not ASD?
Right. Very good question. It's not a silly question. Suppose there's an interatrial septum is present, defect is present. So what will happen to RV?
Pressure, volume overload will be there.
Volume overload lead to what? RV dilatation.
Yeah.
So if there's no RV dilatation, there's no volume overload.
Okay. Okay. But in these images, sir, we are not able to trace the complete septum. We can see some gap in the septum. Maybe that
Interatrial septum.
septal.
Interatrial septum, right?
Yeah, yeah. So how to confirm that it is only interatrial septal
Defect is not there.
defect is not there. How to
Put a contrast into it. Agitated saline contrast.
Okay. On
So
echo?
if echo, yeah, we'll show you agitated contrast saline echo.
Okay.
Switch on colors. Go to subcostal window, switch on colors. If there is a hole, the blood will flow across it, the colors will flow across it.
Okay.
And the dictum is when the hole is smaller, if suppose ASD is smaller, which is not seen in this normal picture, there will be always a turbulence.
Okay, yeah.
Will be mosaic patterns.
Yes, sir.
आप मॉर्निंग में नंबर ऑफ टाइम देखो, अपने वॉश बेसिन में आप करके देखना कल सुबह, बड़ा मग लेके पूरा भर के वॉश बेसिन में सडनली डाल देना. So water will swirl around in that through the hole through which is going out.
Yes, sir.
So what is my LA pressure? LA pressure is 10. RA pressure is 5 or 3. So when the blood is flow from 10 millimeters to 3 millimeters of blood pressures, there will be a turbulence across that ASD.
Yes, sir.
Correct?
Yes, sir.
All right.
Yes. Thank you, sir.
Any questions? Or we call it a day, call it a night rather.
So sometimes we see.
Ravi Shankar, go ahead.
Sometimes we see biatrial enlargement, sir.
Correct.
Without much of stenosis in the
Correct.
mitral valve and tricuspid valve.
Right.
So what is it, sir?
Sometimes we see bilateral enlargement. Rhythm is sinus or
Sinus.
Sinus.
Yes.
Put a halter to these patients. You'll find these people are intermittent atrial fibrillations.
Oh, okay, sir.
And majority of them, they are elderly populations.
Yes, sir.
I'm presenting one topic that the thoughtful of my ideas, can we prevent atrial fibrillation in elderly populations?
Okay, sir.
I bet for this topic in 2012. I was looking for a grant of almost 12 lakhs rupees to work on that particular paper. Nobody came forward, not in India. I did not have the funds.
Okay,
2022, this paper was published from US. Ditto the same one. I was looking at many people presenting with biatrial enlargement in normal sinus rhythm.
Okay, sir.
And when I looked at these people in detail, I found that they were getting intermittent atrial fibrillations.
Oh.
And this intermittent atrial fibrillation was the reason for their biatrial enlargement.
Okay, sir.
In our lab, we can tell you the patient of heart failure with preserved ejection fraction, who's going to go into atrial fibrillation.
Okay, sir.
That's
based on the Holter.
Not based on Holter, based on LA strains now.
Okay, sir.
Based on LA strain, we can tell you that this patient is mostly going into atrial fibrillation due course of time. So be proactive in preventing him from atrial fibrillations.
Okay, sir. Okay, sir. Thank you, sir.
Thank you, Red. Anybody else?
Sir, one more question. You were saying.
Go ahead, Ravi Shankar.
Based on the, we will get to know whether it's LVH or restrictive cardiomyopathy, hypertrophic cardiomyopathy.
Correct.
That thing, I want more clarification, sir.
Normally, when you have a LV hypertrophy, what will happen to your ECG?
Is LVH?
Correct.
Yes, sir.
If there is no LVH and there is hypertrophy,
okay, sir.
That is deposition disease.
Okay, sir. Okay.
And that one of those deposition diseases, amyloidosis. Dr. Deepika Joshi.
Sir, the difference between eccentric and concentric LVH.
Parasync short axis of papillary muscles, concentric LVH where RWT more than 42,
Okay,
And
sir.
LV mass more than 95 in females, more than 115 in males. That is concentric LVH. If you are RWT normal with a mass increase, this is eccentric hypertrophy.
Okay, sir. Thank you, sir.
Kamal Kishore?
Sir, there was two gradients in once you showed me in last session,
Yes,
hypertrophy. Two
correct.
gradients. What was actually didn't get it.
Those two gradients, one
It is
gradient was
mid
coming from the apex, second gradient was coming from the mid cavity.
Okay. So we have to measure for both the gradients, right?
Yeah, we will measure both of the gradients. But what is the utility of measuring those gradients? You know, that is a hypertrophy which is happening both at the apex and at the level of this thing, mid cavity lesions. But we can't do anything for those subset of populations. That hypertrophy, if there's no ECG, there's significant ECG changes in the variant of hypertrophic, non-obstructive or obstructive cardiomyopathy, what options we have as on today? Except for use beta blocker and do AICDs. Fortunately, one drug is coming up that is with the name of Mawa Captain. Very expensive. It costs about 2 lakhs rupees a month in US. I don't know how much would be cost in India. It'll be marketed by BMS, Bristol Myers Squibb. I'll let you know. I'll be doing a workshop in Delhi on that drug and not drug, basically demonstration of LVH in cases of hypertrophic obstructive cardiomyopathy. We did it in CSI in December last in Lucknow. We did a live transmission from our own lab. And we have selected like 5 centers or 6 centers in India. First, Bombay is going to do it. Mumbai is going to get it done. Then there are 5 or 6 cities we are conducting this workshop of identification of LV hypertrophies. So we are the one in Delhi. We'll be doing it our own center.
Commenting on the the RA enlargement and the RV size, will we be having class on it later in the course of time?
Commenting on RV size,
RA enlargement and RV, like
oh,
RV
we have a right. This is a right heart and pericardium.
Okay. And secondly, okay, so even constructive pericarditis will
Yeah,
be
we'll be dealing it constructive versus restrictive cardiomyopathy.
okay, great. Thank you.
So we'll talk of right heart diseases, then we'll talk of pericardium. We'll start with pericardium, pericardial thickening, intrapericardial fat. Then we talk of pericardial effusion. Then we talk of tamponade. Then we talk of effusive constrictive pericarditis. Then we talk of constrictive pericarditis. Then we talk of constrictive versus restrictive differentiations. All right. Shall I stop over here? Anybody, any questions? We are almost what? 11:40. So I'll take my attendance quickly. Many people have already disappeared.
Sir, I have one question. So I'm working
Go
as
ahead,
an
go ahead.
intensivist. Sir, I'm working as
Mohammed
an
Ismat.
Yes, sir.
Online 1. Yeah, Ismat.
The last question, sir. You said that the clot was there. If you find any clot, like multiple clots, that will be a very for patient. It will be a like a life-threatening decision.
Yeah, that clot. Yeah. Go ahead.
At that moment, as an intensivist, what shall I do, sir?
Heparinize them.
Okay.
Look, I don't use low molecular heparins in these people. I'll try to do regular heparins.
That's what. Yes. Okay.
And second important thing is very controversial answer. Like maybe if the clot is large enough, I'll go for surgery.
Oh, yes, sir. Yeah. Okay.
The only 2 options are left. Either you wait, watch, and see.
Okay.
Let the things happen.
Yes.
Or you be a proactive.
Yes.
Is it difficult? I'm not saying that whatever I'm saying is correct. It's not correct. I can't take that patient for surgery. So I'll be very proactive in doing a good amount of heparin. Regular happens.
Thank you so much, sir. The lecture was fantastic, sir. Thank you so much.
Abhijit, anything before we take attendance?
No, sir.
All right, so let's call one by one quickly. One, Dr. Muzaffar, I could see Dr. Muzaffar over there.
Present, sir.
Dr. Abhijit More was present. Navakan,
Present,
Yes,
sir.
sir.
Survasi,
Yes, sir.
Shiva Kumar, Dr. E. Shiva Kumar, 5 number. Chirag Gurbani,
Yes, sir.
Mahua Roy,
Yes, sir.
Deepak M,
Yes, sir. Present.
Pratik Rajesh Shaw,
Yes, sir. Present, sir.
Ramatar Sharma,
Present, sir.
Madhu Seni. All right, Prajakta Pote was present. Shushma Kirti Gaurav,
Present, sir. Present.
Dr. Kirana, Major G. Kirana, Raghuvinder HH,
Present, sir.
Dr. Vikram Bhagchan Khut, Lavdeep Seni was present. Rezul Seni,
Present, sir.
Gaikwad Anshuman Jai Singh, Shantu Mal was present. Tajinder Kaur was present. Lavkesh Singh Parihar.
Present, sir.
Then Ravi Shankar was present. Multiple questions. Abhishek Gaudar,
Present, sir.
Chandrakant Patil,
Present, sir.
Ashish Rathore, Renu Duhan,
Present, sir.
Kamal Kishore was present. Deepika Joshi was present. Shankar Kapra,
Present, sir.
Subhashish Das, Madhav Bansal was present. Veena Yogesh Bang was present. Chaitanya Bujbal. Maximum question today was asked, replied by 2 people. One was Dr. Veena Yogesh Bang and Dr. Shahbaz Karim was amazing. I really got impressed with him. So absentees for combined program is Dr. Shiva Kumar, 1. Then second is Dr. Madhu Seni. Third is Major Kirana Ji. Fourth is Vikram Bhagchand Khurd. Fifth is Anshuman Jaising Gatwad. Then sixth is Ashish Rathore. Seventh is Subhashish Das. Eighth is Chaitanya Bujbal. Let's move on to online. Mohammad Ismat was present. Priya Bhatta Das was present. Priya Ravinder Singh.
Present, sir.
Done. Then we had Ravi Kumar Nimala present. Shamin Sultana.
Present, sir.
Shahbaz Karim, amazing, was present. Satyam Likha. Tejasvi Mathur. Muhammad Arman Jaid. Qasim Ali was present.
Present, sir.
All right, dear. So we have absentees in online is one is Satyam Likha, second is Tejasvi Mathur. So with this few words, let me say thank you. Good night. Shabba khair. Stay safe. And we see you next week.
Thank you, sir.
With testing my own skill, how much I've taught you correctly.
Thank you, sir.
Thank you, sir.
Good
Sir,
night. Bye-bye.
Thank you, sir. Sir. Hello, sir.
Yes, go ahead, dear.
Sir, actually, for MCQ learning, I didn't find any books, sir. Actually, I wanted to learn more with the question and answer session, sir. For that, any books are available, sir, in market?